The growth of the maxilla is for today, and I just wanted to look at what the learning objectives were. So we're talking about the midterm. The midterm in this class covers all of the information on facial growth. Okay, that's why it's set at the end of the facial growth lectures. Okay, and then Bruce Latimer comes in and does the cranial nerves, and he does all that stuff. Okay, so the facial growth piece is all there. It's short answers, so it's like you ask a question and then you're supposed to write a short answer. And people always say, well, what are you going to ask questions about? The questions will be exactly what the learning objectives say. Okay, so if you want to know how to study for it, look at the learning objectives and make sure you know that. Okay, for example, we're going to talk about growth of the maxilla. And so a fair question would be, why isn't there room for third molars to erupt at age 16? Because the learning objective is to understand why third molars don't have room to erupt at age 16. So see how it would work? Okay, and so it says know the pattern of displacement of the maxilla. So a valid question would be, describe the pattern of displacement for the maxilla. Okay? We can even diagram the pattern of remodeling, right? You should be able to do that. So maybe a question is diagram the pattern of remodeling, right? So probably what I'll do is I'll pick one of the learning objectives from each lecture and ask the question about that. And then you'll have to answer them. That's the way to work it. You'll have an hour, so there'll be short answers, right? And then you can go on your break after that. So we were somebody was asking me, I don't mind changing the exam, but just so you know, in case you want to know, oh, what should I study or how should I study for it? I'm not trying to trick you, I'm just trying to tell you that I'm going to try to do it as straight up as I can. I have no reason to try to trick you guys out. So I'm trying to get you to understand these basic things. So if we look at now, I'm going to go to the board here in a minute, which means that when we put it on the board, then it's important stuff. Okay, last time we talked about the cranial base, all right? And what the keys of the cranial base was that the face is built on the cranial base, right? The cranial base is our foundation. So we've got the foundation, you're going to build the face on that. So we're going to start now with the maxilla. And so if I draw on the board the cranial base, do you remember the anterior cranial base and the posterior cranial base? The junction here was the sphenoid bone. And the anterior cranial base is associated with the ethmoid, and the posterior cranial base is associated with the occipital. So, and the brain would be out here, okay? So the maxilla is suspended from the anterior cranial base. So the anterior cranial base goes from the sphenoid bone up here to the frontal bone, and the maxilla then, and the nasomaxillary complex is suspended from the anterior cranial base. So when we look at the maxilla, and then we look also the other component part of the maxilla is the maxillary teeth. This is associated then with the anterior cranial base. Does anyone remember when the anterior cranial base essentially slows down growing? When we get fusion of the sphenoethmoidal synchondroses. Remember the synchondroses are like the growth plates of the cranial base. So when does that growth plate fuse? 7, exactly. So after 7, okay, after 7, the growth of the maxilla is due to the 2 basic processes that we always have to think about. Okay, what are the 2 basic growth processes for bone?
Displacement.
Exactly. And displacement is the movement of the entire bone, right? And then the remodeling is the surface changes on that bone. So you would have a valid question if you said, now for the maxilla, I know that the maxilla is going to be displaced. Okay? So you would want to know the direction of displacement of the maxilla during normal growth. And the direction of displacement of the maxilla is downward and forward. So the maxilla is displaced downward and forward. And what that means is that if you're tracking the maxilla and you would put an implant, something like a label or something like an implant, in the bone of the maxilla, and you would put another one in the anterior cranial base, you would see that these 2 points are moving apart. Because the maxilla is being moved bodily downward and forward. When that happens, necessarily what's connected to the maxilla? The maxillary teeth. So the maxillary teeth are carried down with the maxilla as the maxilla is displaced downward and forward. What do we call that displacement of the dentition? If we call the movement of the maxilla itself primary displacement, the fact that the teeth are carried along with it, we have a different name for that, right? That's movement that occurs not because of the tooth movement, but it occurs because of the movement of the maxilla. So the maxilla carries the teeth downward and forward. The teeth then are secondarily displaced by that movement. The primary movement is the maxilla downward and forward. So you've got the maxilla going downward and forward and the maxillary teeth going with it. Now, if you look, and you guys have now been to do sealants, right? Mm-hmm. At least once. So you've seen at least one kid in 2nd grade and one kid in 6th grade. Probably more than one at this point, okay? And remember what I said to look for. I said when you do that, you're looking at this child and they could open and close their mouth, and you looked at where the maxillary teeth ended, you probably noticed that whatever the last tooth was, and if it was in the 12-year-olds, in the 2nd graders, it was probably the 6-year molar, that there wasn't a whole lot of space behind that 6-year molar in the 2nd graders. Did you check that out? Okay. And the other thing that you should notice is that the size of the teeth, okay, the size of the teeth in that 6-year-old, so the size of number 8 and number 9, okay, is adult size. So the teeth erupt adult size. So in that 6-year-old or that 2nd grader, you noticed that the only thing that they had in their whole body that was adult size were their permanent teeth. Okay? If you would imagine that same 6-year-old or that same 8-year-old or 7-year-old, I guess if you're in 2nd grade, you're going to be somewhere around 7, I guess, right? So it's 6.5 to 8, something like that. But if you think about that, imagine that child with feet the size of an adult. Okay? They would look goofy, right? They'd have goofy feet, like goofy from the, or hands, or anything else the size of an adult, but it just sticks out. So it's not surprising then that parents come in when these permanent teeth come in and they think they look weird, right? And your answer as the dentist is that's because they're fully grown and the rest of your kids not. Okay, so it's like if anybody have a dog, you know how dogs' paws are really big? You know, then they grow into their paws, right? Well, humans grow into their teeth. Okay, so the dog paws are bigger than they should be, so puppies have these huge paws. But for humans, it's the teeth. So this size tooth is going to fit when that person's 20 years old or 18 years old, when they're done growing. That's when that tooth is going to look normal. When it first comes in, it looks strange. Because not only do you have that, but then you have the lateral incisor, right? And then what's right next to it is that deciduous cuspid that looks like almost nothing, right? So it's like just like this one, because the deciduous cuspid is one of the smallest teeth, right? So you've got like these huge teeth, and then you've got this little tooth here, and then you've got, you know, going back, you've got the first molar, and then the second molar, second deciduous smaller as you go back. But because we're juxtaposing this really, really small deciduous tooth next to these huge teeth, you're gonna get questions your whole dental career about this. Okay, so you wanna know what the answer is, and that's the answer. So these are fully grown, these are baby teeth, and that's why these are what they should be. And you know, the tooth that used to be here was just this little deciduous tooth, right? Just this little deciduous tooth like that, which matched much better because they were much closer in size to the person that had them in their mouth. So, the other thing that's going to happen to you is that people are going to expect that because of their whole life they have looked at people growing, okay? And when we see changes in the growth of the face, the changes that we see in the growth of the face occur here in the front, don't they? You know, in other words, they know that the nose gets bigger. They know that this part comes forward. They know that the mandible comes forward. They know that everything's in the front. So what doesn't make sense then is that if all of this change is occurring in the front of the mouth, how come my kids' teeth, if they come in crooked, don't naturally straighten out? Because that makes sense, right? They came in, they're fully grown, and if the child's going to be growing, then there ought to be more room for these teeth, and they ought to outgrow it. They ought to outgrow this problem. Okay? They can outgrow the relative size of the teeth, but within the arch, within the dental arch. If we now took this arch and we flipped it up like this, and we looked at the maxilla from down below, okay, and we looked at the incisors here, and we looked at the incisors here, okay, there is no bone growth in between the teeth. Why? Why can't the bone just grow in between the teeth? Why can't it grow in the front in between the teeth? Why can't bone grow in the middle? Yeah, because it can't grow interstitially, right? It can't grow interstitially. And if you could get interstitial growth of bone, then you could essentially grow the maxilla bigger in the front and the teeth would have room. But that's not what happens because bone can't grow that way. Bone can only grow on a surface. And it can only grow if there's some sort of a space that's created by a displacement force. Because bone can't push on itself, right? Two bones can't push themselves apart. What happens in the cranium here when we've got the two parietal bones? What pushes the parietal bones apart? The growth of the brain, right? The soft tissue growth of the brain displaces the bones apart, and then we get remodeling at the sutural surfaces. The sutures can't push. It's got to be something else, okay? The same thing we talked about in the cranial base, same thing that's happening in the cranial base. What's pushing the ethmoid bone and the sphenoid bone apart? Is it bone? No. Is it cartilage? Why? Because cartilage can grow interstitially. So there's a cartilage here, and there's a cartilage here. So in both of those instances, the displacement comes not from the growth of the brain, but it comes from growth and division of the cartilage, so that the cartilage is able to push the bones apart. It gets a little bit less clear in the maxilla. In the maxilla, it's a little bit less clear what's causing this displacement to occur, the underlying cause. Because we don't have like a really good soft tissue mass that's growing like the brain, and we don't have something that looks like a growth plate like we have in the cranial base. So we don't have those two things, and those are the most obvious things. So what we know is that the maxilla is being displaced downward and forward, but there's a question as to what's causing the displacement. What do we know it cannot be? It cannot be bones pushing on bones. We know that that cannot be the reason. So what are we looking for in the midface now that could grow interstitially. And what cartilage is in the midface? Draw on your anatomy now. I'm going to tell Dr. Landers about your anatomy knowledge in the midface. What's the cartilage that sits right in the middle? The nasal septal cartilage, right? So you ever heard of somebody say they have a deviated septum? That's a deviated septal cartilage. So the septal cartilage is a midline cartilage that separates the right and the left half of the nasal cavity. Okay? And it's joined inferiorly, okay, to the maxilla. So the maxilla then has sitting right on top of it the nasal septum cartilage. And the nasal septum cartilage then connects up to what bone? I'm going to tell Mike, if somebody knows the bone that's the spot that engages and articulates with the superior surface of the nasal cartilage, he'd be so proud of you. The vomer. That's okay. I'm not going to tell him. Okay, but you said ethmoid, which is also there too. So it's a combination of the ethmoid and the vomer. But if you'd have come up with a vomer, Mike would have been so proud. I'll tell him. Somebody came up with it. I don't even know who it was. Okay, it's because actually the vomer has a groove in it, and the groove's called the vomerine groove, and in the vomerine groove is where the nasal septal cartilage sits. Okay. So people said that, hey, we're looking for something that can push or drive the maxilla downward and forward, and what we see is, in fact, there's this cartilage here, the nasal septum cartilage, that's situated right in the middle, and although it's not a growth plate, it is cartilage. So it's capable of interstitial growth, but it doesn't have that cool, histologic structure where for sure it's like lining up and pushing that way, okay? In fact, the cartilage is a little bit like some of the other cartilages that we have, the structural cartilages here, okay? So the nasal septum isn't a perfect example. It's not a perfect example, but it's at least one of the things that people say is responsible for the downward and forward displacement of the maxilla. Now there's another thing that people think might be involved, okay? What's the primary function of the nasal cavity? What's the smell and breathing? So respiration and olfaction. So respiration. So as there's another sort of theory that says the function of respiration of respiration, as an individual gets bigger, you need to have a bigger airway. So what's driving the maxilla downward and forward is this underlying need to breathe. Okay, so there's basically, no one knows the answer, and the answer is probably, it's somewhat a combination of these two things. It's probably more than one reason, more than one cause of the maxilla being displaced downward and forward, and you should know both of them for the boards and things like that, okay? So, sometimes people will call the nasal septum one Scott's theory, and they'll call the respiration the functional matrix. They call it the function, and then they add functional matrix. And they would say this is sometimes associated with the person called Melvin Moss. So the name Melvin Moss I can't remember Scott's first name right now. But people don't use his first name when they talk about it anyway. They say Boss's theory or Scott's theory. But you might want to just put this in your notes. I'm not going to ask something silly like that, but the boards might. You know, you get to your boards, they're talking about, because they have to answer a multiple choice question, and so they could say like, you know, one theory of midfacial growth, a theory of like how it gets displaced, is the nasal septum theory, true or false? Okay, and then, or they might say something along those lines. So it's good to know it, but to me, what's important for you to realize is that this bone is being displaced downward and forward by some combination of either interstitial growth of cartilage or expanding functional, the expanding functional matrix of the respiration, okay? And that's what's moving the maxilla downward and forward. Once you get the movement of the maxilla downward and forward, you then have a mechanism for increasing your arch length. Because as the maxilla is displaced downward and forward, the general remodeling pattern in the maxilla is upward and backward. Upward and backward. The back of the maxilla, this little part right back here, the back part of the maxilla, okay, this back part of the maxilla, people refer to it as the tuberosity. The tuberosity of the maxilla. And the maxilla, when we say maxilla, I say it like it's one bone, but is it one bone really? It's two, it's a paired bone, right? So the maxilla is the plural, it should be maxillae or something for one, right? So you've got a left and a right, okay? So you've got two tuberosities, one on the left side and one on the right side. And when you put your finger in the back of the patient's mouth and you're on the last molar, okay? Beyond that is the tuberosity. So the tuberosity is generally considered to be the most posterior aspect of the maxilla. Okay? So you ask yourself, I know the palatine bone is there too. So anatomically, where is the palatine bone in the maxilla? Because what happens is the tuberosity is here, right? And the tuberosity is here. So this is where the arch sort of goes around. So where's the palatine bones? Mike will be so proud if you know this. Okay? They're in here, right? And they're like the L-shaped bone. So they form sort of the very, very back of the maxilla called the palate, right? The palatine bone. But when you're putting your finger back here, you're putting your finger on the maxilla and the tuberosity. That's where the teeth develop. Then the palatal bones don't have anything to do with the dentition. Okay? The alveolus is totally contained within the bone we call the maxilla, or the left and right maxillae. Okay? So, what's happening back here? What's right behind now? What's right behind those? Okay, here you go. You see what's that? That's the palatine, right? And this is the tuberosity, right? So what's right behind that? Do you know what that is? The hamular notch, yes. This little wing here and this little wing here, it's called the pterygoid plates. The pterygoid plates of the sphenoid bone. I'll pass this around, but notice how the pterygoid plates of the sphenoid bone butt up against the maxilla, and you can't get any growth there, right? You need displacement in order to get growth back here. But I'll pass this one around so you can see those, and you can see the palatine bone there at the same time. This one, the maxilla is sort of missing. So you just have part of the maxilla, and then you've got the pterygoid plates there. But you can look at this person, and you can see that we're missing here. This is where the sphena occipital chondrosis would be, and you can sort of peer in and see the sphena moelus chondrosis. So as those things go around, because here's what we got here. So anything good? No, this one's really not that good. Well, here's sort of an interesting one. I'll start this one in the back so you can see it. But you see, this is the maxilla, okay, and it's just tethered right there to the pterygoid plates. So this is just part of the maxilla right here. This is just the posterior part, sort of cut through. Okay, so just sort of maxilla. So, in order to get room, then, in order to get room in these kids, if now we look at the tuberosity like this, and then I look at the first molar tooth that's here, okay, and I've got the tooth here, a lot of times when you look at x-rays, you'll see the other molars right here. They're sort of stacked in the tuberosity. They're sort of stacked up there in the tuberosity. So if you continue this to the front, you know, you've got bicuspids like that, then you've got the cuspid, then you've got the lateral, then you've got the central, okay, and then the alveolus is this part. So the point is the bone is moving this way by the process of displacement. And as the maxilla is getting displaced downward and forward, we're able then to add bone here on the free surface, which is the tuberosity. And as that bone is added like that, the dentition, the teeth, can you see this? The teeth now start to erupt into that new bone. So that tooth erupts into the new bone like this, and then eventually in the sixth graders, when you were putting your finger back there, you were now putting your finger on the second molar, which is where you're supposed to be putting that sealant stuff. You know, you're putting it on there, and you could see that now there was a new end to the arch. I guess we don't have anything. I don't know where my eraser is. All right. So what happened was, you got new bone here so that you could get another tooth in, right? And then this bone continues, and now you got that situation, okay? Now we got this situation. And up here now is the third molar. So the question that I have, and that's on the learning objectives is, right, okay, why doesn't the second molar, the 12-year molar, have room to come in your second graders? Why does the 12-year molar not have enough room in the second graders? Pardon me? Their nose is too small? What's going to happen to the maxilla between age 7 and age 12? The maxilla is going to get displaced downward and forward, and you're going to get new bone at the back. And so the reason why the 12-year molar doesn't have room at age 7, okay, is that the maxilla is just not done growing, and that's where the new bone is formed. So the new bone, unlike what all of your patients think, the new bone in the maxilla is done in the back, which they will not understand. I can guarantee you they won't understand that, okay? Because it goes against everything that they've seen in their whole life. So it makes no sense to them that there would be new bone in the back. Okay, it would make total sense if you said, you're gonna get more bone here in the front and those teeth are gonna straighten out. It makes no sense to them that there's gonna be more. So it's very easy for someone to tell a patient that there's not enough room for their tooth to come in, and it's impacted. In fact, you could tell every 7-year-old that the 12-year molars are impacted. Would that be true? No, they're unerupted. Okay, they're unerupted. A tooth isn't impacted until it's physically stopped from coming into the mouth and it's supposed to be in the mouth. That's when you know it's impacted. It's not impacted just because there's not enough room for it. Okay? So otherwise, we have unerupted teeth. Okay, unerupted teeth. And then we could also have impacted teeth. But the differential diagnosis of impacted molars is much trickier than, say, canines, okay? Because when a canine goes to the roof of the mouth, you know, if you're normally expecting a canine to come in next to that lateral incisor, and all of a sudden the canine is lingual and it's behind the central incisors, you pretty much know that tooth's not in the right spot. All right?
Could you repeat the definition you said of impacted?
Impacted is a tooth that's impeded from coming into the mouth when it's aged according to the normal pattern of rupture. It should be in the mouth. So in other words, you can't say that the upper central incisors are impacted in someone who's 3 years old, right? But if someone who's 9 years old doesn't have their upper central incisor, there's a problem, right? So the thing about dentistry and the thing about clinical practice is recognizing patterns. Remember we talked about that, I think, about playing chess and recognizing patterns. So recognizing patterns that you don't normally see. So when you're seeing kids and you're seeing these second graders, you're expecting them to have 4 upper incisors and 4 molars. I mean, actually 8 incisors and 4 molars, right? 6 and 6. They should have the same number of deciduous teeth as permanent teeth in second grade. Okay? So if they don't have central incisors, I'm going to tell you that's not normal. That's not normal. If they don't have a first molar at age 7, if they don't have their first molar, that's not normal. There's something going on. So what you have to do is you need to, like, that's where the doctor part comes in, right? That you know what you're supposed to be seeing, and then you see that you don't see that, and then you've got to figure out why. Okay, go ahead. If the central incisor is not erupted in a 9-year-old, it's impacted. You know, it's something's keeping it from coming in. You know, there's a couple of different, now we're getting into what are the reasons, so there's lots of reasons why teeth don't come in, but the main thing to do now is to realize that it's supposed to be there and it's not there. The next step is why, okay? Is the why that normal growth is gonna fix it? Probably not, okay? Is the why for a 12-year molar that's not erupted in a 7-year-old, that's probably normal growth could still fix that, right? Because normal growth, normally where are we getting the bone? Normally we're getting the bone in the back and not in the front. That's the key. Go ahead.
So if you have like supernumerary teeth that are like stuck, is that impacted or unerupted?
Yeah, supernumerary teeth are, you know, there's a couple different kinds of supernumerary teeth, okay? A supernumerary tooth can erupt, and it's still a supernumerary tooth, right? Supernumerary just means extra tooth.
Yeah.
Right? So now, but sometimes the presence of a supernumerary tooth can cause the delayed eruption of a permanent tooth that's above it, because you know it's not supposed to be there. So in that case, the permanent tooth is impacted, but the reason it's impacted is because of the supernumerary tooth. Because a couple common ones are the one right between the front teeth. They call it a mesiodens. Okay, and then another one that's common is in the back. They call them paramolars, where you get extra molars. Those are the two probably the most common supernumerary teeth. Yes.
In the cases where some kids randomly, like they have a lot of eruptions super early, is
Yes.
it because they have a lot of growth?
Oh, that's a great question. The question is, some kids get their teeth earlier than others, and that's probably mostly genetic. Like, so most kids that got their deciduous teeth late get their permanent teeth late. Kids that got their deciduous teeth early get their permanent teeth early, and there is a range, okay? It doesn't necessarily mean that, okay? However, you definitely want to wait until you're pretty sure growth is complete here before you make the call on a molar not coming in. So, you know, you could see it is possible that a 6-year-old, if they are premature birth or something like that, might not have a 6-year molar yet. But if they're a 10-year-old or an 8-year-old or so, and that's why we take x-rays to see what's going on. Okay? So we take x-rays to see what's going on, and when we take x-rays, we can see into the bone and we can see into the tuberosity. And if you look at the way the x-ray is taken for these skulls that are going around, and you look at the x-ray, most x-rays that we take are sort of side view x-rays like this, panoramics and things. So you can sort of see the back of the maxilla. So we can see that tuberosity on the x-ray. And we can see these teeth developing, and we can see what's going on. And so all we want to do is like evaluate that, just, and then evaluate whether or not the condition is quote unquote still normal. That's our diagnosis. That's what you do when you're looking at patients. That's oral diagnosis. Looking at something and knowing whether or not it's an abnormal finding. Yes?
So what causes the teeth to erupt and why doesn't it always happen like at that same
That's,
time on each?
okay, there's a couple things. What causes teeth to erupt is an interesting question, all right? That no one, again, knows the exact answer to, okay? What we know is that teeth start to move towards the occlusal plane and start to break into the mouth when about 2/3 of their root is formed. Up until that point, they develop within the bone. There must be some sort of biochemical signal that initiates that eruption pattern into the mouth. Because a tooth that's just a crown doesn't have any eruptive potential. It's got to have about 2/3 of the root. So between 1/2 and 2/3 of the root. Ask Dr. J that. Maybe it's changed since I was at dental school. But that's what, the other thing that's interesting is that humans only grow, remember I was talking about growing pains? Teeth only erupt at night. So teeth only erupt at night. So whatever's doing it, it's got to be the changes that occur in hormones and signaling and growth hormone and things like that that are occurring when you're sleeping. Because the same thing that's turning on the body to grow is making your teeth erupt. So teeth erupt at night.
Is that why people don't have head breathing like 24/7?
People can do it, but it doesn't. But it works almost as well when you just do it when people are sleeping. So a lot of things that you want to modify growth, whether facial growth or whatever, you really only need to do it when someone's sleeping because that's when the teeth are moving, and that's when the bones are growing. So some people will say, "I'm going to do it in 24 hours," but it's not like you get twice or 3 times as much. You might get 10% more because you're going to get some physical movement that you wouldn't get, but it's most effective at night. Okay? So now, getting to my learning objective, yes?
Would you consider it impacted if you, like when we did scans, I saw a kid that had teeth on the right side fully erupted unless it had.
Oh,
not.
there's another great clinical finding. Was this when you were in the, oh, great observation. Okay, this is what you want to do. See, as a clinician, did you all get a chance to see this? You did? Up and down that, yes, okay. That's a great observation. People are bilaterally symmetric. Okay, so a great indicator is what's happening on the other side of the mouth. Okay, so if the person has the upper left central incisor and they don't have the upper right central incisor, is that normal or not? Okay, and the observation is, first you see that, and that's a great observation because you should be bilaterally symmetric. And the next thing is that we know people aren't perfect, right? So about how close should the right and the left sides be? People say about 6 months, which you wouldn't know without somebody just saying. People looked at it, and after about, if the tooth's been there and the other one hasn't come in for 6 months, there's a problem. There might be a problem. But if it, you know, like last week, this was it, and now I don't see that other one, maybe not, right? So it's somewhere between, you know, a couple months, you get to 6 months, then you start to get worried. That's a great observation. They should have pointed that out so that people, I'm pointing it out. You're going to do more sealants?
Yeah.
Next year.
Oh, not till next year. Try to remember that. Okay, try to remember that. Bilateral symmetry is a really good thing to look at from a clinical standpoint. So my learning objective for you is if the 12-year molar doesn't have room at age 6, then the third molar might not have room at age 16. Why? What could still happen? What do you want to know? You want to know when, the maxilla stops growing. So when does this maxilla stop growing? When do you stop getting this process? And the skeleton matures at about 25 years of age. So up until age 25, you may still erupt your third molars. After that, it's probably not that likely.
But it can still happen.
After age 25, it's probably not going to happen, but you don't necessarily have to have them out because all impacted teeth are not a problem. We're getting beyond like, you know, what this class. I'll follow you through the next 4 years and we'll talk more about teeth.
Okay.
But
I know
yes,
a 25-year-old that, like current 25-year-old who has just the bottom molars,
Yep.
the third molars and not the top.
yep, sometimes that happens. You know,
Like, are we waiting one more year to
well,
see
here's
if they
the
can
thing.
top, or-
What you'd want to know, based upon just what I've told you now, you'd want to know what? How much root formation there's been, right? If the root is fully formed and it's not erupted, there's not much potential for it. If it's still just a crown, it's probably not ready to come in. You know, that would be the next piece of information. What's the potential of that tooth to still erupt?
Is it possible to just like not have it at all?
It's possible that they're not even there. I mean, you know, the most common tooth to be congenitally absent is one of your third molars. Okay? So having one missing third molar congenitally is actually the most common. Okay, then the least common are all four missing and all four present. Okay, and so then all the patterns. But what happens, and again, this stuff Dr. J should be covering. I'm going to tell her. Okay, basically what happens is you've got a first bicuspid and you've got a second bicuspid. Okay, and then you've got a first molar and you got a second molar and you have a third molar. Okay, as you go within a series of teeth, okay, like the first molar is the most stable genetically. Okay, so it's the most stable genetically. The second molar has a little bit less stability, and the third tooth in a series has the most wobble genetically. So that's always happening. So in other words, the first bicuspid is going to be generally always there and always formed pretty well, right? If we're going to have a problem, it's going to be with the second bicuspid. Just like with the incisors, you've got the central incisor and the lateral. The central is the primary one. That's the one that's under the tightest genetic control. And then the lateral has more wobble, which is why we see these weird shaped laterals. You know, you can get peg shaped, you can get all pear shaped. You know, there's all different kinds, okay? You know, where centrals are more consistent. Okay, I want to get through. Everybody should know that answer. Everybody should know this now. I mentioned this first. Yeah, but this is important to know. I'm going to bring this down. If you had crowning of these teeth, because you have a midline suture, you could therapeutically, with a palate expander, widen the maxilla. Right? And that's a really, really common orthopedic procedure in the maxilla that works because it's actually two bones. So this suture fuses sometime around age 12. But up until that time, if you put orthopedic force on the maxilla, you'll actually separate the maxilla right here, and that is one way you can get more room for teeth in terms of treatment. But it doesn't happen naturally. There's a bunch of different ways, but basically you push out the teeth with a force that's strong enough to separate the bones. The younger you are, the less the force has to be. Okay, we're essentially simulating displacement with that. Now, last point. Last point, and then we're going to be almost done here. Okay, stay with me for one more minute. Get that up here. If we look at the maxilla, from the side, okay, and we look at the palate, and we look at the alveolus here, and we look at something like this, where this would be the upper incisor, okay, this would be the upper incisor, and then the molar would be here, right? Okay, that would be the molar, okay. What's up here? What's above the maxilla? The nose. But the maxillary sinus, actually, that's a good Yeah, that's also an answer. The maxillary sinus is above the alveolus. I was really talking about the palate. But right above it, and it's important, right? It's important clinically, right? Because you've got the roots of the teeth sometimes are almost in the sinus, right? And you could take out a tooth and you could perforate the sinus, and there's all kinds of problems. So you're right. I was thinking in my mind though, what about more in the middle, right? So the sinuses are sort of on the edges, but I'm thinking about right in the middle. What's right above it's the nose. So with maxilla, well, that's weird. Oh yeah, so the maxilla, if we look at the maxilla, the superior surface of the maxilla is the floor of the nose. And the inferior surface of the maxilla is the roof of the mouth. So the roof of the mouth and the floor of the nose are the same bone. Okay, so it divides the nasal cavity from the oral cavity. The bony division is the maxilla, and also the palatine bones. And then the soft tissue division is the soft palate. Okay? So as you get into embryology, you start talking about that. Here's the important thing here. The remodeling activity on the nasal surface, is resorption. And on the oral surface, if you put your tongue on the roof of your mouth, you're putting it in an area, in a child anyway, if you take your finger and you go on the rugae or the roof of their mouth, not the alveolus so much, but the rugae there, that's an area of deposition. Superior to that is an area of resorption in the floor of the nose. So what's happening is the maxilla is getting displaced downward and forward. And so if I asked you, are there instances in facial growth where the depository surface, the remodeling, is moving in the same direction as the displacement? Yes, because you would say, I remember Dr. Hahn said, the maxilla is moving down and the palate is depository. So yes, sometimes remodeling occurs in the same direction. Okay? If I asked you, does sometimes remodeling occur in the opposite direction, you would say, yes, because the maxilla is being displaced forward, but I'm getting remodeling in the tuberosity. And there, the displacement is going one direction and the remodeling is going the opposite direction. So there are two different processes and they don't always go in the same way. Does that make sense? Okay, so those are the things that you want to do. If you look at the book, you'll see that there's some patterning things. I hit the highlights here, okay? I hit the highlights that you want to know. You know, that the tuberosity is depository, okay? The roof of the mouth is depository. The nasal surface of the maxilla is resorptive. Those are the high points. But if you look, you'll look, there's a bunch of little arrows on everything, right? Because it's growing in 3 dimensions. Just be sort of aware of what the general pattern is and the general pattern for the displacement. Displacement's easy, it's downward and forward. Okay, and in different people it's more downward, it could be more forward. It's not always exactly that way, but it's the general direction. And that's what makes people grow differently, and that's what makes people look differently. Okay, any questions? Because we're done with, out of time. I know it's like me, my attention span is like 50 minutes, yeah.
I just had a question about the palate expander.
Sure, yeah.
If you were using the palate expander, is there anything that you have to do to the mandible to match your
That's one of the points that's really interesting, right? Because the mandible, you just got the alveolus sitting on top of the corpus, right? So there's no way to expand the mandible except to tip the teeth out without surgery or something. So even though we can make the maxilla bigger, we're actually constrained by how big the mandible is. That's a good point, yes. There's no easy way to make more room in the mandible, which is why people sometimes have teeth removed if they have a lot of crowding to straighten their teeth, because there's no way to make more room. Whereas if your upper teeth are crooked, you can make the bone bigger, wider.
When they're growing, like say, you put a palatal expander in around like 7 or 8, Does the mandible passively grow?
The mandible, the corpus does not, but a lot of people feel that because the teeth interdigitate, as you expand the maxilla, the lower teeth will upright somewhat, and you'll get some lower expansion. Sometimes people actually physically move the teeth on the lower tooth, but they're just moving the teeth, they're not separating the bone.
Is that bad for like the forces on the teeth?
You know from occlusion, you want axial loading. So yes, I mean, that's why the teeth should upright like that, because they're axially loaded. Because, lower teeth, if they come in lingual and upright buccal naturally, right? Whereas maxillary teeth come in buccally and upright lingually. That's a pattern on the sides, right? It's this, or it's this. So a tooth, a lot of times you'll see, like if you look at those 6th graders, if they had a 12-year molar that wasn't quite in yet, it'll be a little bit leaning towards the cheek, because it hasn't quite had enough room to upright all the way into the arch. So sometimes they'll come in before there's quite enough room in the tuberosity, they'll come in a little bit facing buccal, and then as there's more bone, they'll upright, they'll come to the normal position. Yeah.
So then,
Okay, we're talking about mandible next.
alright, cool.
Don't worry about mandible, you're getting ahead. You should have lots of questions about the mandible. Okay, we're doing 2 lectures on the mandible because it's twice as complicated as the next. So, mandible for next time. Yes. Sure.
You said that your molar doesn't have enough room to come in because the new bones.
Okay, so George has a question, and I just want to go over because it's a really important point. Okay, at age 7, the 12-year molar isn't likely to have enough room to come in because we haven't had the displacement of the maxilla with the consequent remodeling or deposition of new bone in the tuberosity. Okay, that's the most likely reason that 12-year molar is not in at age 7. Now at age 12, it could be, there's just a little bit delayed growth, which somebody suggested there. There could be actually a problem. You'd have to look at it a little bit more. But yes, at age 7, it's clearly, there's not been the displacement yet. There's not been the new bone that's added. Good point.
You have all 4 molars with full dentition.
Yes.
You still typically have, and that's their 2 less you have.
Yes, in fact, the question here is, do you still have a tuberosity even if you have all your 2 molars? And the answer is yes. There's just no teeth stacked in the tuberosity. And what happens is, if you take the 3rd molar out, if you go in here and you take the 3rd molar out, a lot of times you destroy the tuberosity. It's supposed to house the last tooth. So there is damage to the tuberosity if you take the tooth out. To get a normal tuberosity, there has to be a tooth at the distal end of the arch.
Is that why they like?
What?
What is the tuberosity?
The tuberosity just finishes off the arch. It's just where the arch ends. It's the last part there where the alveolus, it's really the last alveolar bone in the oral cavity is essentially what the tuberosity becomes. It's sort of an active growth site, and in the end, it's sort of just the end of the alveolus.
Does that explain, I'm not sure which days you prefer to take wisdom teeth out once they're before they're.
Well, first of all, people, extraction, when they extract teeth, the extraction of teeth is generally done because of caries or periodontal disease. So it's not generally done just because of where the tooth is in the mouth.
What for
Now,
the 3rd molars?
3rd molars are just like any other tooth. They could be normal. If they're erupted, there's no reason to take them out. It could be a hygiene issue, so you have to teach the patient how to clean them. But it would be just like when that old joke, just brush the teeth you want, right? So the rest of them will fall off. So what I'm saying, sometimes because of the access to the 3rd molars, it's hard to keep them clean. And sometimes it's also difficult to restore 3rd molars because, in some people it's getting pretty small back there. They can't open that wide. It's hard to even get the handpiece in there and things. It's much better to just not let them get decayed because they're hard to restore. So some people will take them out because they're not restorable. They can't get back there. But normally, you don't take a tooth out just because it's the last tooth. Yeah.
By alveolus, do you just mean the alveolar bone?
Alveolar bone, right? Alveolar bone is just a part of the bone that houses the teeth. We'll talk more about that. When we talk about mandible next week, I'll go over all the parts, and it'll be a little clearer, because in the mandible, it's really clear what's the alveolus and what's the corpus. Whereas in the maxilla, it's a little fuzzy, like where the teeth end and exactly, what happens with the alveolar bone in the maxilla. The question was was
Corpus.
we're gonna talk about that next time.
Oh, okay.
He's getting ahead. He's getting ahead.
And then at what age does the maxilla finish growing?
I usually, age 25 for the skeletons is a good one you say. When is it sort of active growth really slowed down? Somewhere around 25. Okay, he was talking about terminology, exactly what is the alveolus and exactly what is the tuberosity, yes.
So why do dentists choose to pull out your unrounded third molar or your 25?
I don't know that. I've been asking that question for 30 years. So anyway, yes, I'm trying to change that by explaining to you why not to do it. And then when you get in practice, you can not do it. And then I won't have that question for years. Because you're right. All right, if you have any of my bones, bring them up. Otherwise, we'll see you next